So guys, continuing with the Virology. Okay, so we just completed the general virology, and before getting into this section, you have to just go through the general virology once, and so that only majority of the job is done there, and we are just separating the facts learned there and distributing it over under several topics. So starting with the herpes viride. Okay, so herpes viride is a DNA or RNA virus. Can you recall? It is a DNA virus, and it is given as HHV. Okay, so HHV, totally how many types of HHV? 1, 2, 3, 4, 5 and 7 and 8 comes under the same group, and HHV1 is similar to HSV1, HHV2, HSV2, HHV3 is called as herpes zoster. Okay, 3, there is a difference in 3, that is herpes zoster, and 4E Epstein-Barr virus, and 5 is the cytomegalovirus, the largest in among herpes viridae. Can you remember the largest among all viruses is the poxviridae? And HHV6, HHV6, HHV7, HHV8, both the same name. So general property is this 150 to 200 nanometers, icosahedral as I have said, and double stranded DNA as I have said. And can you remember the single stranded RNA, that is the parvovirus? I think so. And shape, the exception is the pox virus. And coming to the subfamily, alpha subfamily, beta subfamily and gamma subfamily. So the species is the herpes simplex 1, 2, alpha means 3 groups, first 3 groups, and site of latency is the neurons. So replication is very short here. Okay, this is important, and this is a previous question. And yes, going with the classification. So classification is the alpha, beta and gamma, and in alpha we have 3 groups: herpes simplex 1, herpes simplex 2, herpes simplex 1, herpes simplex 2 and herpes zoster virus. And the site of latency is the neurons. Replication is the short 12 hours, that is important. And coming to the beta, and the beta we have cytomegalovirus. Can you remember cytomegalovirus number? That is the 5. Epstein-Barr virus is the 4, and the cytomegalovirus and this 6th and 7th group. Cytomegalovirus resides in the glands. It's the largest, so it is the biggest organs like kidney, glands, and also 6 and 7 resides in the T cells, and it has the longest 24 hours replication period. And coming to the gamma, so gamma is the last 8 and 4, especially herpes virus 8B, that is the form, and Epstein-Barr virus 8 also look like B, right? So B, so B cells. Okay, so simple. So the replication time is variable here. Then starting with the herpes simplex virus. So first virus among the family. We are going to read about only important points about the all 8 subgroups. Then coming to the HHV1 and HHV2, herpes simplex 1 and herpes simplex 2. It is always to take this in comparative study, so that it will make recalling and retention very much easier. Then the transition. The transition is the to the mucus and upgraded skin. HHV2 means 2 persons are involved. When 2 persons are involved, that is called as the sexual or vertical transmission. Sexual transmission when the mother and child are involved, that is vertical transmission. HHV1 direct inoculation by the into the mucosa. Then latest can see HHV1 is the trigeminal ganglion. 1 look like T and 2 look like CS. Second is a sacral ganglia. Then coming to the ages of first we are beginning with the children. So next we are coming to the adults. Adults only can have sexual relations. Children is not possible. Orofacial lesions, skin lesions above waist. Okay, above waist lesions are HHV1, and HHV2 means genital below waist and allonatal transmission. Then culture. So can you remember HHV1, that it's primary line we read about chicken embryo fibroblast, that yes, that thing. So chicken embryo fibroblast doesn't grow well, but it grows well. Neurovirulence is less, though it resides in the herpes 1 resides in the neurons and trigeminal ganglion predominantly. Both results there, but the neurovirulence is very less in HHV1, whereas in herpes simplex 2 there is more, and drug resistance is less and drug resistance is more. Okay, that goes in par with the neurovirulence. And herpes simplex 1, it shows more than 80% antigen homology. And coming to the clinical features, orofacial lesions. Most common site is the buccal mucosa. I will just do the thing and you can do the question. In the buccal mucosa and the gingivostomatitis. Okay, and gingivostomatitis and herpes labialis. Okay, so what is the thing? Most common site is the buccal mucosa. As I said, that mucosa is the way by which herpes 1 is spreading, and the primary lesion is the gingiosomatitis, and recurrent lesion is the herpes labialis. Okay, so recurrent lesion, so herpes labialis. Primary lesion is the gingiosomatitis. And coming to the nervous system features, predominantly seen in type 2 variant only. And when the parenchyma is involved, it is called as encephalitis, and the meninges is involved as meningitis. So meningitis M. So M, mollaret meningitis. Okay, mollaret meningitis. So what is mollaret meningitis? From the mollaret we can note that it contains double L. So mollaret double L contains. So what does the double L signify? Means it's a lymphocytic. It's a recurrent. Then also RE, mollaret rit. So it's a recurrent lymphocytic meningitis. That is the mollaret meningitis. Then coming to the encephalitis, most common cause of acute sporadic viral encephalitis. Okay, most common temporal lobe. Most common cause of HSV. Encephalitis is the most common cause of acute sporadic viral encephalitis, and most common is the temporal lobe. Okay, so that is the question. That is the important question here. Most common is the temporal lobe. Can you remember negri body is in which part of the brain? It is in the cerebellum and in the hippocampus. Then coming to the clinical features, nervous system and encephalitis, others. What is the others? In healthcare workers, and fingers are involved. It is called a herpetic whitlow and herpetic gladiatorum in wrestlers. Restless herpes or mat pox, MAT, restless mat. So just remember restless here. And health nurse in herpetic whitlow, the nurse name is whitlow. And eczema herpeticum erythema multiforme. Eczema herpeticum erythema multiforme. Okay, so herpetic whitlow, herpetic gladioforum, eczema herpeticum erythema multiforme. Then coming to the ocular lesions, one is more common than two, though neuronal is more common than two. Severe conjunctivitis, dendritic ulcers, corneal blindness, that is important. It can cause blindness. Okay, then coming to the clinical features, genital lesions are more than two, but ocular lesions are at least above the waist, so the ocular lesions are more than one, genital lesions more than two. So what is the genital lesion? Is a bilateral painful tiny vesicular ulcers with or without linguinal lymph node. Okay, then coming to the visceral and disseminated lesions, so mostly it occurs in immunocompromised only. So what is the presentation? That is the hepatitis, liver, lung, tracheobronchitis. Hepatitis, tracheobronchitis. Coming to the lab diagnosis is by the cytopathic effect. What is cytopathic effect? Means cellular changes is seen due to the virus. That forms the basis for the laboratory diagnosis for herpes virus family. Then virus isolation, antigen detection, DNA testing and antibody testing. So what is that cytopathic changes? Means it can see by Zang smear. So what is Zang smear? Some changes in the base of the vesicle can be seen. That a stain is the genes or right stain or toluidine blue stain. Okay, so what is the why is toluidine blue used here? Toluidine blue is used for the property of metachromasia exhibited. So okay, then yes, what is the microscopic examination finding? So microscopic examination finding is the lip-Schultz body. I have said you lip-Schultz, lip. Okay, it's above the waist, so it is that only. Lip-Schultz body. Sensitivity is low. Disadvantage is cannot distinguish between HHV1, HHV2 and herpes zoster 3. 1, 2, 3, no sensitivity, no differentials, but lip-Schultz body can be seen, and genes or right stain that can be used, and also this also can be used. Toluidine blue can also be used, and Zang smear, Zang cell. What is a Zang cell? Means a ground glass nuclei. Okay, the ground glass nuclei is the Zang smear. Okay, what is herpes simplex virus? So what is the three main characteristic feature is that it shows multinucleation, it shows molding of nuclei, it shows margination. Okay, it shows multinucleation, molding of the nuclei and margination. Then coming to the lab diagnosis, virus isolation, lab diagnosis, virus isolation, most definitive primary cell line only. Antigen DNA, and coming to the DNA testing, PCR most sensitive. This can distinguish between 1 and 2. Then coming to the antibody, can distinguish between 1 and 2. What is the drug of choice? Is the acyclovir. What is the dose? Is the 800 microgram. Okay, 800 micrograms per day we have to give. And mechanism of action, it inhibits DNA polymerase, and when resistance develops, phosphornet is used. Okay, then coming to the herpes zoster, varicella zoster virus, type 2 virus. So it can be given into chickenpox primary, and also in zoster or shingles means it's a reactivation in adults, latency usually involved in a ganglion. Okay, then coming to the chickenpox is the primary. Herpes labial is done, right? And then herpes simplex 1 and 2 is over, and 1 and 2 is over. 1 and 2 is over. Next, coming to the this thing HSV. So under HSV we saw about chickenpox and zoster shingles. Zoster is the primary children, and zoster shingles is the unilateral. That is very, very important, mainly due to the reactivation, maybe the ganglion adults. Chickenpox incubation period is 2 to 3 weeks. Rash distribution, bilateral, diffuse, centripetal distribution. Centripetal, that's very, very important. Centripetal starts on the face trunk first, and then to the flexor. Okay. Centripetal distribution, centrifugal spread. Then coming to the rash distribution, we saw about that centripetal distribution, and rash distribution can also be called as a crops. Fever with every crop, fever with every rash, new rash. There is going to be, I am just going to have only crop here, fever with every crop. So then what is the in adult, what is the presentation in an adult? It is mostly bullous and hemorrhagic, most severe forms only in adults. Okay, then coming to the complication in adults, because of the reactivation, right, and also the immunity is very much developed, that causes more damage to the adults, that is by the secondary bacterial skin infection. And the most common extracutaneous complication is the aseptic meningitis, most common. And most common is secondary bacterial skin infection, and most serious is the varicella pneumonia. Extracutaneous complication, most common CNS, but most serious is the pneumonia, especially during pregnancy. But most common is the secondary. What is the most common cause? Is the secondary bacterial skin infection. Most common presentation, complication, extracutaneous, most common CNS, most severe pneumonia. Okay, just have it simple. Then in pregnancy, how is the spread? Is still with the transplacental route. And coming to the fetal congenital varicella syndrome. Fetal congenital varicella syndrome. Okay. Microcephaly, yes, brain development small, limb development small, cicatricial skin development small. Brain development small, microcephaly, limb development small, limb hypoplasia, cicatricial skin lesion is seen. Not neonatal varicella, intrapartum, it is not teratogenic. Okay. Then coming to the chickenpox epidemiology, period of infectivity, 2 days before the rash to 5 days after the rash. Epidemiology, chickenpox is the third. So have 2 to 5. That is the magical number here. Third virus, so 2 to 5. So immunity is lifelong immunity. Reservoir is the humans. Source is the patient. Carrier none. This is important. Carrier none. And then zoster reactivation, more than 60 years when there is a decrease in the immunity. Then coming to the zoster shingles reactivation, the decrease in immunity. Then how is the presentation in zoster? Mostly in adults we saw the most classical is the segmental and unilateral. That's very, very classical here. Then coming to the complications in zoster and shingles. Post-herpetic neuralgia, pain at local site is the most common. Pain is the most common thing, and zoster ophthalmicus and Ramsay-Hunt syndrome. I will explain the Ramsay-Hunt syndrome next. So what is Ramsay-Hunt syndrome? Just remember the face. Okay, so facial nerve palsy. Okay, done. Then vesicles in external auditory meatus, tympanic membrane. Okay, what are the opening is present in the face is the mouth, so the tongue. So vesicles are seen there. Vesicles classical. Okay, so facial nerve done, and tongue done, external auditory meatus done, and tympanic membrane done. So that is the Ramsay-Hunt syndrome. Why it happens? It is because of the virus is released from the geniculate ganglion. So these locations are the distribution of the geniculate ganglion here. Okay, I am just saying Ramsay geniculate. Okay, you have to pick it from there. Done. Then coming to the vaccine. So vaccine has to be in live attenuated vaccine, Oka vaccine, varicella zoster, 2 doses. It's a third virus. So 2 days before the rash to 5 days after the rash, Oka strain is used, and varicella zoster virus. And the treatment is by the acyclovir. And varicella zoster immunoglobulin can be used less than. This is very important. Less than 96 hours is very important. Okay, very important names question. Less than 96 hours. So what is the 96 hours means? It's 4 days, less than 4 days, and neonates born to mother with chicken pox. Then a few words about the Oka strain. 2 doses, yes. If unimmunized, 2. If 1 dose earlier, 1 more dose. If episode of chicken pox, 1 dose. Protects against chicken pox and shingles. No protection for post-herpetic neuralgia. That's very important. And MMR, okay, in 9 months and 18 months. 2 doses I've said now. 9 and 18 months. Okay. Yes. So we have just completed herpes 1, 2 and 3. Can you give the management of acyclovir? Yes, very good. And for herpes simplex 1 and 2, that's also acyclovir. Okay. Then vaccine for can I remember any vaccine for this HSV 1 and 2? Is it possible? No, because no vaccine for that thing. And for the second, only Phoscarnet for the resistant strain, Phoscarnet is being used. And for the second one, we saw about that this one. What is that? Oka strain. Okay, Oka is the MMRV. It's a live attenuated strain. It's very good with that. Good to go. And HHV4. So then we are good to go with the HSV4. Can I remember the name? It's the Epstein-Barr virus. So the pathogenesis of Epstein-Barr virus is the Epstein-Barr virus attacks the B cells. The receptor is CD21 or CR2. That is the receptor there. And one second. There's a small problem there. Yes. So CD21 and CR2, that is the most common receptor involved there, and 2 genes are involved. What are the 2 genes? LMP1 and EBNA2, latent membrane protein and Epstein-Barr nucleic acid 2. Latent membrane protein and Epstein-Barr nucleic acid 2. So the cluster of differentiation 21 and the complement receptor 2. Okay, so the 21 and 2, that forms the combination of the antigen and the receptor, and latent membrane protein and Epstein-Barr nucleic acid activation of NF-kB pathway. Natural NF-kB pathway. And then the clinical features are the infectious mononucleosis, malignancies and others. What is the infection? Malignancy is the carcinoma and the lymphoma. Okay, so carcinomas most common is the gastric cancer, lymphoepithelial carcinoma, and lymphoma is the post transplant lymphoma and Hodgkin's lymphoma, and lymphoepithelial lesion, maltoma. Others, Duncan syndrome, lymphoproliferative disorder, hairy cell leukemia, oral cell leukemia. These are the causes, clinical features of Epstein-Barr virus. So Epstein-Barr virus main is the infectious mononucleosis, malignancies, gastric malignancies, lymphoma, Hodgkin lymphoma, post-transplantal lymphoma, and in post-transplant only Epstein-Barr virus is important, and in others it is the Duncan syndrome, lymphoproliferative disease, and hairy cell leukemia. It is also called oral hairy leukoplakia, and Epstein-Barr virus, it's also called as the kissing disease, come to because of the close contact, and the glandular fever with lymph nodes enlargement, and most microscopic examination we have downy cells, ballerina skirt appearance. Okay, so ballerina skirt, kissing disease, everything seems so weird now. Downy is the boy fell in love with ballerina's skirt. So CD8 T cell, he's in CD8 T cell soldier. Okay, so Downy love with ballerina. Then coming to the Epstein-Barr virus associated malignancies, the carcinoma, the lymphoma, and gastric cancer, lymphoepithelial carcinoma is the most common cancer, and this Hodgkin lymphoma and post-transplantal lymphoma is seen. Then coming to the Epstein-Barr virus, lab diagnosis is by the antibody detection, heterophile antibody and specific antibody. Heterophile antibody is the antibody agglutinate RBCs of different species. Example, sheep RBCs. Okay, sheep RBCs. then specific antibody, then a heterophile antibody test, aka Paul bundle test. So what is the Paul bundle test? Epstein-Barr virus. So nowadays it is the monospore test is being used. So what is the principal? Antibody to viral capsid antigen is VCA, early antigen is EA, Epstein-Barr nucleic acid is already said that latent membrane protein is there, right? So viral capsid antigen and early antigen, the antibodies are produced against it, and antibodies are produced against Epstein-Barr nucleic acid. Treatment is by the acyclovir for oral cell leukemia, and rituximab. It is an anti-20. Okay. Then coming to the cytomegalovirus. Cytomegalovirus is omega. It's the largest virus of herpesviridae. It causes congenital, perinatal, immunocompetent, and immunocompromised affects that individuals only. And most common intrauterine infection associated with the congenital defects. Very, very important. Most common intrauterine infection. And coming to the defects, most common is the leptosplenomegaly, jaundice, petechiae, and least common is the microcephaly, IUGR, prematurity. Most of the neonatal disorders are very, very least, and most of the postnatal disorders like hepatosplenomegaly, jaundice, petechiae are more common. So perinatal CME infection, delivery, and lactation, and that is the mode of transmission, and usually asymptomatic. Immunocompetent individual adults develop mononucleosis like syndrome. Okay, so then what is the age, or how to differentiate between Epstein-Barr virus and cytomegalovirus? So infectious mononucleosis in Epstein-Barr virus, whereas mononucleosis like symptoms in HHV 5, cytomegalovirus, and 6 atypical lymphocytes are seen in both. Heterophile antibody is more in infectious mononucleosis, negative in mononucleosis. Specific antibody is present in both. Okay, then immunocompromised hosts like AIDS, most common is the CMV radiochorioretinopathy. This is an organ transplant of CMV is the most common infection. Okay, CMV is the largest thing, right? So it attacks the weakest people so easily, like that only. AIDS organ transplant like that people. So reservoirs are the humans. Transmission most common by the oral and respiratory route. Transplantation and sexual also occurs in cytomegalovirus. Then coming to the inclusion bodies, both I already said that it's both, and blue vaso, blue indication ovuli present in both regions. Virus is synonymous with that Reed-Steinberg cells. Okay, virus isolation, most ideal cell line, and antibody. So virus isolation, most ideal cell line is the human fibroblast. Okay, so human fibroblast it is a secondary cell line. I have already discussed above. So antibody is by the ELISA, and antigen detection is by the for the PP65, and DNA for the PCR. Specimen washings and urines can be used. Okay, then coming to the ganciclovir in case of resistance, phosphorant. Another one organism where we give phosphorant is the HHV1. Then coming to the herpes virus 6. So how does it binds to dash cells via dash receptor, T cells via 46 CD46 receptor. Two variants 6A 6B are children or adult. So what you have to remember is a TCD46. So we have just done with the CMV, and then with the HHV6. First point is TCD46. Okay, that is the first point there. Then sixth disease, okay, Rosella infantum, and 6B, children most commonly involved, second type. And the mononucleosis like syndrome, I already said it. HHV5 and HHV6 both causes mononucleosis like symptom, and human herpes virus 8. Okay, say less than 7 is not the significance. So coming to the 8. So what is the intermediate vascular? Okay, Kaposi sarcoma, second most common in HIV. First most common is the CMV. The second most common cause is HHV8. Most common site is the skin, especially the lower limb. Second most common site of okay. And primary effusion lymphoma, PEL, primary effusion lymphoma, CD30 plus, CD38 plus. Castleman disease, lollipop follicle. In Castle, lollipop is there. HHV8, I am just going to say only one thing. Lollipop, HHV8, lollipop follicle. That's only that, nothing. Castleman disease, you have to guess from it, and causes are the primary effusion lymphoma, CD30 plus and CD38 plus, and Kaposi sarcoma also in second most common in HIV. So by this thing we have just completed the second part of the virology. It is a small session only. Virology, it will be small, but it will be like a bit it will be like so condensed with mnemonics and stuff like that, but it will be more easy than comparatively with bacteriology. So let's get started. Thank you.